My name is Dr. Ajibola, and in this video, I'll be talking about enterohepatic circulation. So, this is going to be part one of it, and in this one, we'll be talking majorly on the bilirubin. And I have a question here that by the end of the lecture, everyone should be able to know the correct answer to this question, and why we begin the answer for this question. So the question: if 4-week infant with jaundice, dark urine, clear color stool, and enlarged liver, with a total bilirubin of 7.0 and conjugated bilirubin, which also some people refer to as direct bilirubin of 6, and the question is, what's the most likely diagnosis? So A, hemolytic anemia; B, biliary atresia; C, Gilbert syndrome; and D, physiology jaundice. And the answer to this question is biliary atresia. And like I said, by the end of the lecture, all of us should be able to know why biliary atresia is the answer to this question. So let's talk about bilirubin now. Let's talk about bilirubin. So from here, we can see that from our RBC, inside the RBC, we have a very important protein which is called hemoglobin, and the hemoglobin inside the macrophage is broken down into globin and heme. And the question is that what are the indications of breaking down RBC? That we want to have what's called hemoglobin. So what are the indications for breaking down RBC? So number one of the reasons for breaking down RBC is senescent RBC. Senescent RBC. So this means RBC that is more than what? 120 days. Like remember, the normal lifespan of RBC is 120 days. And for fetal RBC, it can actually be less than 120 days. It can be like within 80 to 90 days. So once they are more than once they reach 120, or they reach for fetal, once they reach 90 or 80, then they are going to be destroyed by the splenic macrophage. That's one. Two, another indication for breaking down RBC is if they have abnormal shape. So if they have abnormal shape, anytime you have what's called abnormal looking RBC, the splenic macrophage actually take them out and destroy them and break them down into what's called hemoglobin. And this is an example of what we see in extravascular hemolysis, like in condition like hereditary spherocytosis, erythrocytosis, and so on and so forth, and also sickle cell. So sickle cell disease, sickle cell. Another one, apart from senescent or abnormal shape, another indication for breaking down RBC in the macrophage is if they have inclusion. So RBC with inclusion. An example of this one is N's body. And what control do we see N's body? We see N's body in this is PD deficiency. Another indication for breaking down RBC is if the RBC is coated by opsinin. It's coated by opsinin. And what are the two opsinin that we have? If you remember from immunology, IgG, I also have C3V. So like and you can produce IgG being kind of like autoimmune hemolytic anemia. And in particular, we are talking about the one. Remember, IgG is 1, whereby IgM is cold. So these are all indication for destroying what's called for macrophage, for splenic macrophage to destroy the RBC. So let's go back here. So from the hemoglobin now inside the RBC, we have the globin and the heme, and then the globin is converted to amino acid, and then that amino acid we can reuse it again. And then from the heme now, we break it down to biliverdin by the help of heme oxygenase. So that's the name of the enzyme there. And then from biliverdin, we break it down to unconjugated bilirubin by the help of biliverdin reductase. So by the help of unconjugated bilirubin, and then this form of bilirubin, which is unconjugated bilirubin, is also called the indirect bilirubin. So you can see some people calling it indirect bilirubin, and this form is also water insoluble, so it's not soluble in water. So because it's not soluble in water, that means if it needs to pass through the blood to go to the liver, it's going to need a carrier. It's going to need a carrier protein to carry it to the liver. And then the carrier protein that we want to use here is going to be what? Albumin. So albumin is the carrier protein. And you can see here, albumin combined with the unconjugated bilirubin to form unconjugated bilirubin albumin complex. And then this albumin is to now carry to the liver. So you can see here the uptake of the complex into the liver. And then right inside the liver, the unconjugated bilirubin will be conjugated in the liver by the help of UDP, glucuronic transferase. So uridine diphosphate glucuronic transferase. So that's the name of the enzyme. So this enzyme is going to help us to conjugate our bilirubin. So from there we want to now form what? Our conjugated bilirubin. And this conjugated bilirubin will be incorporated into bile, and then from bile now, so at this point, so it's going to be incorporated into bile and be secreted out from the liver. And then another name for conjugated bilirubin, we also call it direct bilirubin. It's also called direct bilirubin. And then this form of bilirubin is actually water soluble. So this is water soluble. And just some little name here. So this is the liver. So we have the liver here, and here we have our hepatic dot. So this is the hepatic dot, and right here is our common hepatic dot. So this is the common hepatic dot, and here we have our gallbladder. So this is the gallbladder, and this is the cystic dot. So this is our cystic dot. So that's our cystic dot right there. And then this one is the common bile dot. So that's the common bile dot. And then right here is the pancreatic dot. That's the pancreatic dot. And here is the ampulla of Bartter. And then around it we have the sphincter of Oddi. We have the sphincter of Oddi. This is the ampulla of Bartter, and then around it we have the sphincter of Oddi. And this opens to the second part of the duodenum. So it opens to the second part of the duodenum. And that location is actually very important because it's a very important landmark that differentiates the foregut from the midgut. Anything as you're coming from all the way from the pharynx, once you get to that point, that ends foregut, and anything from there all the way down, we start with the midgut. And let's continue. So the bile is going to be secreted into the biliary tree, and once it's secreted into the biliary tree, so from there it can be stored in the gallbladder for metabolic concentration and release, and then from there can be released by the contraction of the gallbladder by the help of CCK. And then once it's released, so it comes out through the common bile duct, and from the common bile duct it comes out through the apple of Vata into the what? Into the intestine, especially the second part of the liver, and it's going to be moving through the intestine. And right inside the intestine, the gut bacteria is going to deconjugate. It's going to deconjugate the conjugated bilirubin. Remember what came in through here is our water soluble, is the water soluble, which is the conjugated bilirubin. So once you get into the gut, so the gut bacteria is going to deconjugate it. So once it deconjugates it, so it will now form what? Urobilinogen. So going to form urobilinogen. And then this urobilinogen now, it has two fates. 80% of it is going to go into the feces. So 80% of it is going to go into the what? It's going to go into feces. So 80% of it by the help of by auto oxidation, it's going to be converted to stacobilin, and which is going to be excreted in the what? In the feces. And this is actually what's known for the nice brown looking color of the feces. So this is what's known for the what? Nice brown looking color of what? For the feces. And that's why if somebody have obstruction here and then we can't form urobilinogen, if there's obstruction and then there is and the conjugated bilirubin cannot come into the gut, and then we can't convert it to urobilinogen. That's why in those obstructive jaundice you want to have pale stool, or you can call it clear stool, or you can call it clay color stool. So the stool is not going to have that nice looking brown color. And the second fate of this is that 20% of the urobilinogen is going to be absorbed back to the what? Going to be absorbed into the blood. So you can see 10% of the urobilinogen is being absorbed back into the blood. So it's absorbed into the blood. And so what will now be the fate of this 20% that is absorbed into the blood? So 90% of it is going to go back to the liver, and then 10% of it is going to be excreted in the what? In the urine. So 10% will go into the urine, excreted to the urine by the kidney into the urine, and then 90% of it is going to go back to the what? To the liver. And this is what we call the urobilin, and then this responds for the what? Yellow color of the urine. So in other words, stacobilin is urobilinogen in the stool, and then urobilin is urobilinogen in the what? In the urine. And then, like I said, so the remaining 90% go back to the what? To the liver. And this is the enterohepatic what? Circulation. So entero from the gut, hepatic circulation. So that's the enterohepatic circulation, this 90%. And in condition whereby somebody having probably inflammation of the liver, like in hepatitis that I'll talk about later, there can actually be decreased uptake of bilirubin to the liver. So like this 90% that's supposed to go back to the liver can actually be, instead of going back to the liver, it can actually be going to the urine. So this 10% can be increased. And that's when we are talking about hepatitis later. You can actually see in hepatitis they actually have increased urine urobilinogen, and that's actually the reason why they have increased urine urobilinogen. So the bottom line of the story is that it is not normal to see bilirubin in the urine. So what's supposed to be inside the urine, based on this pathway that we just go through, is urobilinogen, which is what we see as urobilin. So it's not normal to see bilirubin in the urine. So if you see bilirubin in the urine, if you see the conjugated bilirubin in the urine, that means it's what? Is pathology. And we want to talk about the causes in a second.